The introduction, this I think Dr. Raghu has already told you, and I'll just brief you that these standard treatment guidelines have been developed and prepared to provide quality and standardized healthcare services, and these are systematically developed statements to assist the practitioners and patients' decisions about appropriate healthcare for any specific clinical circumstance. It will serve as a valuable resource because we have, from the evident literature, from the clinicians, and it has been vetted by the highest of the experts to, make final this document. So it will serve as a valuable resource for Ayush healthcare providers and will empower them to deliver the optimal care to the individuals who are suffering from muscular MST. It represents a significant footstep towards a commitment to comprehensive healthcare for the citizens. Its important benefit is that they can improve both the quality and the process of the care and the clinical outcome. Integrating not only homeopathic intervention, but at what level, what role diet has to play, what role yoga can play, and integration of it can bring about the changes in MST, because homeopathy alone cannot bring any change in MST. We need some assistance. So I'll just start with OA directly. So OA belongs to the ICD code 10 code M15 to M19 and ICD 11 code FA00FA05. So now we have presented in the DGHS STGs which you have got, we have presented, I am not covering all the things, but the main things I am covering here. The case definition as per our guidelines, OA is a degenerative joint disease which affects the articular cartilage associated with aging, we all know, and mostly likely to develop the joints which are continuously stressed throughout the years, involving knees, hips, fingers and lower spine region. In India, nearly 80% of the population shows OA among the patients who have claimed knee pain. 20% have reported incapability in the daily activities. 80% of those who have OA have limitations in the movement, and 25% cannot perform their major daily activities. If we go through the ACR diagnostic guidelines.
Previous slide, please. Previous slide. Yeah. Previous slide.
Just sorry.
Before that. Previous one. Yeah. What is that code, madam? I just want to know.
These are the ICD code, these are the code, International Classification of Diseases. We have sub-codes for the diseases. So we have now, it has become a mandate if we have to classify, if we have to specify a disease, we need to classify what are the sub-codes. Now ICD has several codes and sub-codes. So now OA belongs to ICD 10 code in the sub-code of M15 to M19. And if we look at the revised ICD 11 code, this belongs to FA00 to FA05. So OA of knees at one code, OA of hands or hips is of 02. So these are different sub-codes. So here we are, ACR diagnostic guidelines. So I'll just brush through because I think the modern perspective people will be briefing about it. So ACR diagnostic guidelines, if we see the items required, we have hand, hip and knees. So hand pain and aching, if a patient is coming to us, then he must be presenting with hand pain, stiffness for most of the days of the prior month. Heart tissue enlargement of more than two joints of the 10 selected hand joints. The metacarpophalangeal swelling in less than 2 joints, heart tissue enlargement of more than 2 distal interphalangeal joints, and deformity of more than 1 of the 10 selected hand joints. So if we have 1, 2, 3, 4 or 1, 2, 3 and 5, then this in the hand, then we include it as a OA diagnostic criteria apart from the hip now. Hip, again hip pain should be there on most of the days prior month. Radiograph femoral and acetabular osteophytes should be there. Hip joint space narrowing, this we all know. Again, I have just written there. So I'll just brush up quickly. Clinically, if we see the knee pain should be there on most of the days. Crepitus and active joint motion. Morning stiffness less than 30 minutes. Age of more than 38 years. Bony enlargement of the knee on examination. And clinical and radiographically, if we see the knee pain should be there for most of the days prior month. Osteophytes on radiograph. Synovial fluid which is typical of OA, and age more than 40 years. Morning stiffness less than 30 as I told you. So these are the criteria which actually choose if you have to diagnose OA. So these symptoms of hand, hip and knees should be there to fulfill this ACR diagnostic guidelines. Now clinical examination, again we have to, I think this we all know, but I'll just brush up. Look, feel and move for each joint for swelling, warmth and tenderness, the range of motion and the pattern of affected joints such as the knee, both knees, knuckle, wrist or shoulders. During physical findings in osteoarthritic joints, the examination should look at the joint tenderness, any bony enlargement if there, the crepitus, effusions and decreased range of motion, erythema which is generally not present, but if there it suggests inflammation, and if hands are involved, particularly the DIPs and PIPs are involved, then the examiner has to look for the bony enlargement for Heberdens at DIP and Bouchard's notes at PIP.
मैडम वन थिंग जो जॉइंट लाइन टेंडरनेस आपने बता रखी ना इसमें,
हाँ जी,
लाइन में देखिए जॉइंट लाइन टेंडरनेस लिखी ना आपने,
हाँ जी सर.
हाउ मच प्रेशर यू आर गोइंग टू क्रिएट एट द टाइम और टू इल्यूसिडेट द टेंडरनेस,
So,
हाउ मच प्रेशर इज इंपॉर्टेंट.
sir, we can't quantify the patient. As you palpate the patient, it's see, you cannot press the patient. You obviously you have to give a fine hand to that. If you are examining a patient, how can you put a pressure? We can't quantify. This is basically a clinician. I mean, we have never quantified or qualified it, but when we examine, we don't do a pressure. It's with a fine hand we feel. If I'm just doing, अगर आपके knee पे, I mean, सर अगर आपकी नी पे नहीं मैं and that's what I'm saying, let me complete it. अगर आपकी नी पे मैं आके ऐसे ही हाथ करूँगी, अगर आपको पेन है तो टेंडरनेस तो आपको आएगा ही ना.
सीवियरिटी होती है ना, पेन माइल्ड मॉडरेट सीवियर हो सकता है.
हाँ जी बिल्कुल हो सकता है.
मॉडरेट टू सीवियर पेन है तब तो आप लोग छू के पता कर लो.
हाँ.
अगर आपको टेंडरनेस इल्यूसिड करनी तो आप टेंडरनेस इल्यूसिड करोगे कि नहीं करोगे, आप एग्री कर रहे हैं भैया ये
नहीं तो इल्यूसिडेट टेंडरनेस इल्यूसिडेट करने की ज़रूरत नहीं है ना सर. आप अगर हाथ ही ऐसे रखोगे तो वो तो पहले ही टेंडर है ना. What I'm saying is that inflammation can occur in OA. That's what I've said earlier also. See slide. No, the slide is not coming. That's okay. Okay, so principles of management. Now we'll come directly to the principles of management. There are different, and if you see the STGs, we have given the investigations and the differential diagnosis also, everything. But now we come to principles of management because that is the most important area. So if we get the red flag signs of OA, now red flag signs of OA, these signs, please see this line, that these signs have to be assessed before initiating treatment for the need of management consultation through modern medicine. So if these red flag signs are there, we have to refer the patient before we start any management. But yes, we are allowed, we can give any medicines, but these we have to keep in mind. I mean, we cannot continue with these red flag signs, and we cannot tell the patient that to come to us only. Sorry? Modern medicine. I didn't get you, sir. Modern medicine. Why you are? No, any medicine. I'm not saying modern medicine. I'm saying that these. Yeah. I'm saying, sir, I am saying they can go to any stream, but these red flags have to be noticed. I cannot, अगर आप मुझे बोलो कि मेरे पास ये patient आ रहे हैं, ये red flags के आ रहे हैं, मैं बोलूँ नहीं आप मेरे पास ही आते रहो, I will not do. I have to take a opinion, I have to refer the patient to see the severity of these things. He has to be investigated. So the red flag signs with sudden severe pain, buckling of the knee when the knee just goes out, the knees wear off. Swelling and warmth is there, the knee locking is there, persistent pain is there, and even if we see consistent pain after surgery. So these are the red flag signs which we have noted down in these STGs for OA. We have to educate the patient on their diagnosis and what is the possible progression to disability, because they have concerns regarding that. There should be emphasis on the natural history of OA. Therapeutic options need to be discussed to emphasize that lifestyle changes play a major role in alleviating the symptoms of OA, such as exercise and weight control, that will be helpful, and lifestyle changes depends from patient to patient. Now prevention management. Now we have categorized those were the principles of management which we have to keep in mind. Now we have to characterize what is the prevention management and what is the intervention level. So in the prevention management, the primary, secondary and tertiary prevention strategies are necessary to prevent increasing rates of OA resulting from an aging population and increasing rates of obesity and physical inactivity. The non-pharmacological approaches which we have penned down in these STGs are the changes in the diet and the lifestyle, the weight management, we have given various yoga asanas, the exercises which needs to be done, the patient education which needs to be done, and the psychosocial measures which actually play a great role, like reassurance, counseling, education. Thermomodalities do play a role in decreasing the joint stiffness, alleviating pain, which we can do at every stage. Support devices and alteration in, and alteration in activities of daily life. Now the B is the interventions. Now it's not only homeopathic management, but we'll be talking about when a patient comes at level 1. Now here DGHS has created in its STGs different levels. Like if patient come at level 1, level 2, at level 3, what are the preventive and the interventional strategies which should be implemented. So at level 1, if a patient is coming to a solo physician clinic, a health clinic or a primary health center where we have got only optimal standard of treatment and technology and resources are limited, how to go about for that case? So clinical diagnosis, first we'll be diagnosing OA basically clinically, and after a complete medical history, the physical examination will be done. Here we can do only investigations like complete hemogram and X-ray, because it's level 1, so we don't have much facilities. So according to that level 1, we can do the hemogram and the X-ray. Now management, if we see the homeopathic management, so various studies on OA in homeopathy have revealed the potential role of homeopathic medicines in relieving the symptomatic, in giving symptomatic relief to the patients and improving the activity of daily life. But medicines, I have given you a list of medicines like Brineia, Rustox, Lyco, Calcarea carp, Calcarea flor, Thuja, Causticum, Sulphur, Pulsatilla, Medorinum, Graphites, Calicarp, Syphilinum, Sepia, Rhododendron. Now these are the commonly prescribed medicines which we have got from the evident literature, from the clinicians' experiences and the experts' opinion. But this is not my the list that I want you to implement at level 1, because ultimately the totality of symptoms presented by the patient is the sole indicative and guide for treating each patient. These are only a helping hand to you. And then because of the chronicity of the disease, a single dose may not be sufficient. This we all know. The repetition of the doses, potency change, and the remedy can be based on the totality, miasmatic and the R12 observation. So we have given these in the guidelines with the do's and don'ts. And now these medicines again can vary from the, as per the need of the case, depending upon the factors like age, chronicity of the complaints, severe, chronic, how frequently it has to be repeated, what is the nature of the medicine, is it polycrest or acute. So depends. Now we have also advocated that we may use the adjuvants along with these remedies. Adjuvants you may use are the Calcarea for 6x or 12x, Calcarea flor 6x, 12x, ointments, arnica, ruta, ledempal and rustox, and other Schusel's remedy for pain relief like Macfos, Califos, for anxiety, Calimure, Calisulf, Natrum Mure, Natrum Fos, Natrum Sulf, Silesia. So these are all from our source books and the literature we have gathered here. If we see now, apart from the interventions comes the recommended diet and lifestyle, which this STGs has actually paid importance to. So if you see that exercise, we have to advise people with OA to exercise as a core treatment irrespective of the age, comorbidity, pain severity or disability. We don't have to overstrain the exercises, but these are the basic exercises like knee flexion and extension, as you can see. I think I'll just read on, but I think this is, everybody knows this thing, that knee flexion extension, how we have to do lying on the back, and every exercise has to be holded for 10 seconds and repeated 10 times at least. So knee flexion and knee extension can be done. Inner range quadriceps can also be done easily when we just hold a towel under your knee and tighten your thigh muscles. Quadriceps strengthening, again sit to stand. When we sit on a chair with your arms folded, and we have slowly stand up without using our arm, and when upright we have to return again to the chair without using our arms. I think it's visible from here. Okay, so quadriceps strengthening, again a mini squat, using a chair for balance, squat down, bending both knees, but we have to keep the back straight. The squat should not be more than 45 degrees, again to repeat 10 times. We have calf strengthening, heel raises, like using a chair for balance, just standing on toes and back down again, repeating 10 times. This is again a step up exercise which is recommended for OA. Step up 10 times with one leg leading and then repeat with the other leg leading. This is the clam, hamstring stretch, where we have to stand upright and place the foot on your affected leg on a step. Slowly lean forward at your hips until you feel stretch at the back of your thigh. So hold it for 20 to 30 seconds, repeat 5 times. Again the quadriceps stretches, stand upright holding on a firm support, loop a towel so that the stretch is felt in the quadriceps. Again for 20 to 30 seconds we have to hold, repeat 5 times, and again the calf stretch comes.
How long should be continued? These exercises should be continued for 1 month, 2 months, 3 months. What is your these
Sir,
type of exercise? Suppose the grade 1 or grade 2 osteoarthritis is there. Suppose we are talking about the knee joint.
Yeah, okay. हाँ जी बताइए.
We are talking about the knee joint and grade 1, grade 2 osteoarthritis. Grade 3, grade 4 में तो मुझे लगता नहीं है कामयाब होगी, हो सकता है उनको मिला हो रिजल्ट. लेकिन grade 2
तो फ्लेक्शन और एक्सटेंशन तो हो सकती है, नी फ्लेक्शन और एक्सटेंशन में तो कोई ऐसा नहीं है.
ये कब तक करनी है एक्सरसाइज ये तो बताइए.
Ma'am, what is the utility of hemogram you have told regarding investigations other than infective pathology?
Who's there? I can't see your face.
मतलब इसका रिकमेंडेशन आपकी कितने दिन तक है?
Sir, they can say minimum we say thrice a week we have to do. Minimum thrice a week a patient should. How long means? In a day.
What is the utility of hemogram you are
Ma'am,
advising
sir,
other than infective
Sir,
pathology?
sir.
Rest of the infective pathology is not involved.
Sir, I'll come to you. Can I finish him, please?
Madam, I am trying to say the results of this physiotherapy
मैम ये कैन
will
पता
somehow
है एक्सरसाइज
in how
कितने
many
दिनों
days?
तक करवानी है उनको.
Sir,
How long the patient has to continue?
सर वो तो आप डिपेंड करेगा ना, आप 1 मंथ करें उसका चेंजेस तो आप नोट करेंगे. मैं पहले से एडवोकेट कैसे करूं? आई हैव टू ऑब्जर्व. फॉलोअप क्या होता है? अगर हर हफ्ते मैं पेशेंट देखूंगी, पहले फॉलोअप लूंगी, मैं पहले से बोलूंगी आप 2 महीने करो. अगर मेरे पेशेंट को पहले 2 इनमें से 10 एक्सरसाइज में 3 एक्सरसाइज में हल्का सा एग्रीवेशन हो रहा है या कुछ उन बातों से बेटर हो, तो मैं आते ही तो उसको नहीं बोलूंगी ना कि आप 3 महीने तक एक्सरसाइज करो. दैट्स वाई वी आर डूइंग फॉलोअप आफ्टर एवरी 7 days or earlier. आई एम कमिंग टू द फॉलोअप ऑल्सो. So these are the yoga asanas. I have not given all the yoga asana, but this is the Kati Chakra asana, this is the Tad asana, and this is the Urdhva Hastot asana, which is actually these 3 asanas are applicable in OA and RA. Even the Bhujang asana, the asanas I have commonly kept here are applicable both for OA and RA. So these you should advise to the patient, which the patient can easily do. Now this is the Gomukhasana, this is the butterfly pose which we do and which is called the Bhadrasana. This is the Ushtasana, and I think I have done it. Pranayam, Nadi Shodhan Pranayam is the normal pranayam which we do, and Surya Bedi, when we take the from the night nostrils we are inhaling and exhaling. Brahmari is the honeybee. I think you all know, but I just putting the thumb on your ears and just murmuring, because this is a very good pranayam for OA, RA, cervical, any bit. This is a universal thing. It's Brahmari. It's a honeybee which we do. And then comes the yoga into practice and the meditation. Now weight loss. This is very important. I think we always we are focusing on what medicine to give, but we are not actually thinking what these parameters can have a role to play. So that's why I've written here that weight loss, even each kg increases the loading across the knee 3 to 4 times. So weight loss, if substantial, will ultimately decrease the symptoms of the knee and the hip OA. Nutrition should be adequate. A diet rich in A, C, E, K and the omega fatty acids like fish oil capsules should be given, or fish supplements. Restricted diet and lifestyle again is a heading which we have given in the STGs, where we want to tell that we don't need to overeat. I know these are very basic and simple things, but when we see a patient, I think we don't remember such things and we don't keep into mind. So we have substantially mentioned these things so that these things have to be kept in mind. Don't overeat. Smoking has a great effect because it increases the risk of developing OA, which we need to advocate to the men who smoke, because they have more significant cartilage loss and more severe knee pain. We don't have to advocate for vigorous and repetitive exercises. Here comes your answer. Avoid exercising during flare-ups or acute pain. Avoid jobs which require knee bending and carrying heavy loads. Now see, we are not, when we are calling patient at level 1 at any level, we are actually following up at every 7 days or earlier, because we have to take into account all the parameters. Now reviews, whenever you have to review, what review parameters or reviews should include? We should monitor the person's symptoms and the ongoing impact of the condition on their everyday activity and the quality of life. Management of OA in terms of exercise and physiotherapy. Here comes again your answer, that what was the effect of that exercise or particular physiotherapy. So when you are following up with that patient, these review parameters will take into account. Discussing the person's knowledge of the condition, any concerns they have, their personal preferences, their ability to access services, that's a simple thing. Reviewing the effectiveness and the tolerability of all treatments, self-management support. Now at level 1, what is the referral criteria? Either to level 2 or some other, wherever the patient, the referral criteria at level 1 will be when a patient is non-responsive to treatment. Evidence of an increase in severity or complication. It is substantially impacting his quality of life and activities of daily living. Diagnostic uncertainty and uncontrolled comorbidities like diabetes, hypertension or any associated cardiac disease. So that was level 1. Where we had minimum of the investigation. Now level 2.
Up to how long should we have to wait to assess that the treatment is not responsive?
Sir, you are coming, patient is coming after 7 days. आपके पास patient 7 days में ही आके बोलता है मेरे को नहीं है. You can continue for 1 more week. But if after fortnightly also you think that the patient is worsening, we have to refer him. We have to refer him if you think that your medicines are also not acting.
But
Sir,
what happens is that in some homeopathic medicines, they start action very slowly. Means it takes time, like Biotech, Silesia. These medicines, they take action slowly. So, what will be the specific criteria for?
Sir,
we have to follow the science of it.
Sir, हाँ आप अब एक बात बताइए ना, आप अपने पेशेंट को अगर आपके पेशेंट
साइंस 2 हफ्ते में नहीं दिख सकता है.
सर
इम्प्रूवमेंट साइंस 2 हफ्ते में नहीं दिख सकता है.
सर रेफरल का तो क्राइटेरिया ही डायग्नोस्टिक अनसर्टेनिटी है. जब आपको समझ में ही नहीं आ रहा कि मैंने बेस्ट ऑफ द मेडिसिन दी है या अगर उसको अनकंट्रोल्ड कोमॉर्बिडिटी, उससे अलावा तो आपने रेफर करना ही नहीं ना. देन यू हैव टू ट्रीट इट. These are the 4-5 referral criteria which we have given, which I don't think so. जब हमने लिखे हैं, जो आएंगे नहीं, अगर आते हैं वो इन केस में ही आएगा ना, लास्ट 2 पॉइंट्स के. उसमें तो आप इसको ऑब्जर्व करोगे, मेडिसिन दोगे एंड यू विल कॉल द पेशेंट अगेन. सो आई डोंट थिंक सो रेफरल क्राइटेरिया आपको इतनी जल्दी ज़रूरत पड़ेगी. इट्स जस्ट दैट इन केसेस ऑफ लास्ट 2 थिंग्स. सो
मैडम कैन आई आस्क वन क्वेश्चन हियर?
Sir, वैसे I'm open to question, but I would appreciate if we can complete and we can have the questions. Is it okay? Otherwise, as you say, I'm okay with both the things. Because you know it's a long STG. We have to, जो आपने book में पढ़ा है वो हमने PPT की form में लाए हैं ताकि वो, I mean you can all read it and mug it, but again presenting it again.
जो आपका एक्सपीरियंस है वो बताइए, उसमें मजा आएगा.
सर ये हमने जो बनाया है ना सर, ये एक्सपीरियंस और वेट करके ही आया है. मतलब इफ़ यू इट्स अ कलेक्टिव, मेरे एक्सपीरियंस से कुछ नहीं होगा. माई एक्सपीरियंसेस एंड लिटरेचर इज scrutinized by so many people and then it has turned into this document. So at level 2, if we see that's a community health center, the small hospitals with 10 to 20 bedded with basic facilities like routine investigation, x-rays. Now we have come to level 2 apart from the solo physician and primary health centers at CHC. Now again the clinical diagnosis will be same as level 1, but the case which are referred from level 4 or a fresh case which have been coming, which has come for evaluation through any complications at level 2, we have to investigate for hemogram, x-ray, MRI, though will not be available at all level 2. It may or may not be available because that's a basic facility which will be available at level 3. But if required, we have to do. So joint aspiration, C-reactive protein, these are just the synovial fluid examination, uric acid, RA factor. Management will be same as level 1. As I told, the diet, lifestyle modifications, the yoga, exercise, everything will be the same. But for the patients who are referred from the level 1, either we can give, here comes your answer sir, the first point will give you a tinge of your answer also, that for the patients who are referred from level 1, either we can continue giving the treatment what we had given in level 1, or we may appropriately from the presenting symptoms, the case may be reassessed for the totality of symptoms and the treatment may be given accordingly. I am speaking too loudly, that's why. Achha. So for the patients who are referred from level 1, whatever the treatment is given in level 1 may be continued, or we may reassess and on the totality of symptoms another remedy may be prescribed. For the new cases at the level, the medications which are mentioned at level 1 may be considered. However, again the totality and the constitutional treatment stands first. Now at this level, the physiotherapy, other procedures may be considered at the level 2 if the patient is not improving. So you may consider the physiotherapy like exercises, massage and this transcutaneous electrical nerve stimulation. Braces may be done. The occupational therapy like therapeutic activities and exercises to promote gross and fine motor control, the range of motions, endurance and strength, thereby improving their functional abilities. Orthosis or the mechanical aids which protect the joints and help reduce pain by statically holding the joints. So these procedural therapies may also be considered. The recommended diet and lifestyle stands same as level 1. Restricted diet, no smoking, as I told, weight loss, everything same as level 1. Follow up again at level 2 will be at every 7 days or earlier as per the need. Referral criteria same as mentioned earlier at level 1, plus in continuation of those referral points, plus we will have failure of acute exacerbation to respond to initial medical management. Now if we have flare-ups and we are not able to manage, then again it will come under the referral criteria. Advanced stages of diseases like severe effusion, contractures, osteoporosis and deformities. Now we come to level 3. Sorry. So at level 3 we have Ayush hospitals attached with the teaching institutions, the district level integrated state Ayush hospitals, tertiary care hospitals, allopathic hospitals having Ayush facilities, and we have multiple departments. At level 3 facilities for diagnosis and intervention, and they provide additional facilities, must provide additional facilities like dietitians, counseling and physiotherapy unit. So clinical diagnosis again stands same as level 1 and level 2. We have to confirm the diagnosis and severity with the help of the investigations, because now MRI is available at this level. Joint aspiration and synovial fluid examination if required. Again management stands same as level 1 and level 2, but if the patients are referred from level 1 or level 2, treatment whatever is given at the level 1 or at level 2 have to be reassessed, or it has to be taken as a new case, and on the totality of symptoms the treatment may be given. So again the sole indicative is the totality of symptoms. In addition to level 1 and level 2 management strategy, we have a number now. Here at level 3 we can give specifics also. We have advice specifics if required. We are not meeting as a EDL or the as a mandate, but we are at level 3 we are advocating the use of specifics also if required. So because we have a lot like actus spicata, I have jotted down also here, in RA it will come. So homeopathy has a number of uncommonly prescribed medicines which can ease the pain. Then as a supportive, they can be prescribed as a part of supportive management based on the keynote symptoms. And as a part of integrative therapy, additional therapies like cupping, acupressure including massage and acupuncture may be again advised as per the case. So the recommended diet and lifestyle stays same as level 1, level 2, restricted diet and lifestyle, again the points which we have discussed earlier. Follow up is again every 7 days or earlier as per the need. Referral criteria will be the same, plus other modalities which can be considered depending on the case and to rehabilitate properly. The medicines which we have considered at level 3 for OA are Reuta, Phytolacca, Kali iode, Sticta, Sanguinaria, Ferrum metallicum, Ancastra vera, Solanum, Guaiacum, salicylic acid and natrum phos. Again depends upon the various factors, dose, time, duration. Adjuvants is the same. Calcarea phos, Calcarea flor, and the adjuvants remains the same. So here we come to the end of OA. We will start with RA now. So again rheumatoid arthritis falls under the code of ICD-10 code M06.9, ICD-11 code F820.0. So case definition if we look. So RA is a progressive, disabling, chronic multi-system disease which is characterized by pain, swelling and stiffness of the synovial joint. Worse in the morning and periods of inactivity, exhibiting symmetrical, destructive and deforming polyarthritis which affects small and large synovial joints with extra-articular manifestations, which includes fatigue, subcutaneous nodules, drug involvement, this we all know. And they are associated with systemic disturbance and presence of circulating antiglobulin antibodies. The reported prevalence of RA in Indian population as per the revised ACR criteria is 0.75%. It affects approximately 0.3 to 1% of the adult population, with a peak onset we know 40 to 70 years of age, and the prevalence rises with age. Occurs more in female with a ratio of 3:1, and 70% living with rheumatoid arthritis of women. Risk factors we know it's female genetic factors like HLA, DRB1, these everything knows. Environmental factors, exposure to tobacco smoke, air pollution, asbestosis, high sodium, red meat. So, now diagnostic criteria. This is a well defined 2010 ACR Euler diagnostic criteria, which is based on the signs and symptoms, and if a patient presents with the score of more than equal to 6, we say that the patient is having definitive RA. So, what are the parameters which is taken into consideration for the ACR diagnostic criteria are the joint affection. If one large joint score is 0, 2 to 10 large joints 1 score, 1 to 3 small joints 2, 4 to 10 small joints 3, and more than 10 if it includes at least one small joint, then the score is 5. So, after the joint affection, the next parameter which the ACR considers is serology. So, negative rheumatoid arthritis factor and anti-citrulated protein antibody. So, 0, low positive RF and ACPA is 2, high positive RF and ACPA, because ACPA is highly sensitive and specific marker for RA. So, we give a score of 3 there. Duration of symptoms, if less than 6 weeks 0, more than 6 weeks is 1, and acute phase reactance, normal CRP and ESR with a score 0, abnormal CRP and ESR score 1. So, patients with a score of more than equal to 6 are considered to have a definitive RA. However, the presence of radiographic joint erosions or subcutaneous nodules may confirm the diagnosis in the later stage of the disease. So, the criteria is not incorporating these things, the nodules factors. If we see at the clinical examination, pain, swelling, morning stiffness which affects the small joints, basically the wrist, the metacarpophalangeal joints, and the PIPs are involved. DIPs are specific for OA, but their involvement in RAs at the later stage. Flexor tendon tenosynovitis is a frequent landmark. Why I am discussing is because when we consider at the levels, when we see that clinical examination, then these points come into consideration. So, the signs and symptoms we all know: joint pain, tenderness, swelling, redness, limited range of movement, and the deformities, the Botner's, the swan neck deformities, the flexion deformities, ulnar drift of the hand, and MR, and it has RA is actually associated with a lot of extra articular manifestations. Supportive investigations, again rheumatoid factor, as I told you, it may be positive, but it is a non-specific. Anti-citrulinated peptide antibody is highly specific marker, is a sensitive and a specific marker. CRP, ESR are elevated. X-ray may show reduced joint space, subchondral cyst. The juxta-articular rarefaction, soft tissue shadow. Erosions may be detected earlier in MRI than X-ray. And if we see the radiological features of rheumatoid arthritis and bilateral, it is a symmetrical arthritis, marked periarticular osteopenia, widespread joint space narrowing, erosions of the radius ulnar carpal bones. I think this we all know. We will move to the principles of management. Now, again the red flag signs of RA. These signs should be assessed before initiating treatment for the need of management through modern medicine. Again, more visible swollen and tender joints, symmetrical pain, there are more frequent flares up. It is increased stiffness and difficulty bending joints. There are less range of motion, rheumatoid nodules are present. Elevated inflammation markers, feels more fatigued or weaker, having more trouble with the daily activities which is disturbing his daily lifestyle, numbness, tingling in the fingers, and the extraarticular manifestations. So, these are the red flag signs for RA. And again, if we look at the prevention management again requires educating the patient about the disease and its prevention, the rest, the exercises, how frequently we need to educate them. Okay, it has a role to play in improvement and maintaining the range of motion of the joints. Physiotherapy, if we see, so physiotherapy, the splintage of joints in proper position during the acute phase, application of heat or cold can relieve the pain, joint mobilization exercises to be told, muscle building exercises. Again, occupational therapy to help the patient cope with his occupational requirements in the most comfortable way. Nutritional and dietary therapy, again weight loss is recommended for overweight and obese people. as it's a risk factor for rapid progression of joint damage. Interventions again at level 1, where we are visiting a solo physician clinic, health clinic, PHC, clinically diagnosis of RA is based on the signs and symptoms as depicted in the earlier slides with laboratory and radiographic results. Physician needs to do a physical examination to check all the joints for swelling and assess their movements. Look for any nodules on the skin, and blood tests like ESR and CRP can be done to assess the level of inflammation. Again, homeopathic management, if we look, we have a lot of studies, a lot of literature which have indicated that they play a considerable role in reducing the symptoms, its frequency, duration, severity. And constitution has, we are doing studies, and we have done studies where we have seen that constitutional simillimum improves the quality of life of the patients by reducing intensity of pain, limiting disability, and there are minimal use of non-steroid anti-inflammatory drugs and DMRDs also. The medicines which have been listed out here for RA are again the common medicines which have come in RA and OA is Brineia, Rustox, Lyco, Calcarea, Causticum, Pulsatilla, Meadow, Rhodo. Arnica, Ruta, Formica rufa is for here, Natrimure, Phytolacca, Calmia, Phosphorus and Kaliiode. So, this we advocate for our patients at level 1 with the adjuvants remedies like Calcarea Phos, Calcarea Flor. Ointment goes for Arnica, Ruta, Ledempal, Rustox with the Schutzler's remedy as discussed earlier, Ferrum Phos, Calimure, Caliphos, Natrimure, Natrum Phos, Natrum Sulph. So, that will come at level 3, sir. That will come at level 3, where you are using the specifics. So the recommended diet and recommended diet and lifestyle again, rest helps to decrease active inflammation in RA cases. In general, we have to advise the patient to take shorter rest breaks every now and then, and are more helpful than taking long time spent in the bed. Exercise is important. Now, the exercise which we have to do, these are actually, if you look at it, these are a kind of Sukshma Pranayam which we advocate in yoga, these exercises like we do. So, basically this is the exercise pattern, but if you do yoga also, this covers under the Sukshma Pranayam. So, now you have to nod the hand, we have to do, I can't see from here, but nod the hand in the stages like doing this. Then again walk the finger 2 to 5 against the finger 1 by 1 with the palmar side of the hand lying on the table. Place the palm on the flat surface and move the thumb far away from the hand possible. We have to do abduction for the first and then for the second finger, and similarly for the rest of the fingers. When all the fingers are far to one as possible, they are moved back one finger at the time. Spread the finger with the palmar side of the hand lying on a table. I think it's very clear. Then put the tip of the first finger with the tip of the fourth finger, and similarly we have to do with all the fingers so that it makes a circle. So, these are all small joint movement exercises which we have written. Bend the stretched hand from side to side. Sorry. I'll come here. Bend the stretched hand from side to side, like we have placed your palm here on a flat surface. Without moving the lower arm, we have to bend the wrist left and right using approximately 2 seconds to complete the movement. Again, make circles in the wrist joint, this I have told you. Make circles with the shoulders, sitting with the chair with the back free of chair and your hands are placed in your lap. Look straight ahead and lift your shoulders back up and forward in a circular motion, and we have to do it 8 repetitions. After 8 repetitions, go the other way by starting with the protraction of the shoulder and then lift and retraction. Now, put alternating back from the head and loin. I think it's clear. Is it visible at the back? So, I will not. अच्छा वहाँ है ना, ठीक है. Then the gross grip which we have done. Now, this is the clay type of the therapy is the clay which we form as a ball and place it in the palm of our hands and flex our fingers simultaneously and hold for 2 to 3 seconds, release the grips and reassemble therapy. So, it is a form of a gross grip exercises which we have to do with the therapy. Now, finger pinch again, it involves the placing the therapy on a table, pinching with the thumb, index and middle finger in a flexion for 2 to 3 seconds and then release and repeat again. Finger adduction, again make a ball of therapeutic and place it between the index and the middle finger. Place on our hand and squeeze the middle and the index finger. I think this you can all go through it. Wrist extension, wrist flexion, biceps exercise and triceps. So, this we have advised here. Yoga asanas remains the same as I have told you, the kriyas, the kunjal and the kapalbhati, the simple joint movements which we call the sukshma vyayam and which we have just advocated in the exercise pattern. The practices of sukshma vyayam, yoga asana like tadasana, kati chakra, konasana, this I have already told. The gomukh asana, the majri asana I am not told, but it is just lying on the floor and I mean I can't demonstrate it neither. So, you can have a look, it's again a one more amazing asana for here. And then shavasana, makrasana, pranayams. Now, joint care. Under the joint care, we have to include the tools and devices which help with the activities of daily living, like help to get off the chair, toilet seats and bed, choosing activities that put less choosing activities that put less stress on your joints, like limiting the use of stairs and taking rest periods. Health stress management, which can be tapered off by relaxation, deep breathing, meditation, healthy diet as I have told you. Physical therapy, occupational therapy can help develop, recover. Restricted diet and lifestyle again includes the smoking reduction, avoiding activities which cause a flare up like taking up stairs rigorously. High impact activities like running, or football playing, avoid activities that cause your joints to become warm and swollen. And what is happening? I need help. I can't move it. I think I can't.
Ma'am, unless up to there is no interaction, do you think that this is useful?
Ma'am, sir, we are interacting. You are free to interact. Till the slides are there, we can interact.
Mouse you get. Now you can operate. These are self-explanatory.
That's why I'll just go through it. I think I'll just go through the reviews. I'll just go through the important points that we have. So I think at level 1 we have done this. So now I come to the follow-up. Again it is 7 days and our review should again include the monitoring of the patient's symptoms and signs. As I have told you, we have to explain him the understanding of the disease, explain the patient the importance of monitoring their condition. They can't take their thing so lightly, so we have to make them aware of the disease progression at every stage. We have to measure their inflammatory markers like ESR and CRP to assess it. We have to assess for the disease activity as I told you and the impact it is having, and the need for referral for surgery. So now what are the referral criteria for at level 1 for RA? If a patient is non-responsive to the treatment, there again is evidence for increase in severity and complications which is impacting on their life and activities. Diagnostic uncertainty and uncontrolled comorbidities is the same as I told you like that. Now comes at level 2 where we are, the patient comes to the community health centers with the 10 to 20 bedded hospitals. Again and again I am repeating so that it goes in our mind that at level 2 these things are there and the investigations of X-ray are there. Clinical diagnosis will be again same as level 1, or the case has been referred from level 1, or it has to be evaluated as a fresh case. Investigations will again diagnosis, all know this, I will not repeat it. Management is again same as level 1, and the patient again from level 1 we may continue or we may reassess depending upon the totality of symptoms. For new cases again the new medication may be considered. Other procedures, if you look at the OA and RA and cervical at level 2, apart from these management, the procedural things and everything is the same. The parameters are all the more same with a very thin difference distinguishing line. So again here adults with RA, we can advise physiotherapy required under the like encouraging regular exercises or joint flexibility exercises, occupational therapy, a hand exercises program as I had told you, a podiatry if a foot problem is occurring, psychological interventions like relaxation, stress management. Again recommended lifestyle and diet is same as level 1. We have to restrict whatever restrictions we are offering at level 1 goes same for level 2. The follow up is done for at every 7 days or earlier, and the referral criteria again is same as level 1, plus again failure of acute exacerbation to respond the initial medical treatment, and if any symptoms of I've come to oh god, sorry, why it is moving. So here was I, same as level 1, acute I have just told you this. क्यों हो रहा है ये बार बार? Sorry. So at level 3 we have again Ayush hospitals which are attached to teaching institutions, district level integrated state Ayush hospitals, having tertiary care allopathic hospitals which have Ayush facilities, and they must have additional facilities like dietitian counseling. Here again the clinical diagnosis is same as level 1 and level 2, and we have to confirm the diagnosis and the severity with the investigations like MRI, ultrasound, joint aspiration and synovial fluid. Management again same as level 1 and 2. Again I will not repeat these things because we have to continue with the level 1, level 2 or reassess the case as per the totality of symptoms. The medicines which we advocate for RA at level 3 are Colophilum, Guacum, Stellaria, Calcarea flor, Formica rufa, Lithium carb and Chamomilla, and the tissue remedies falls the same. Recommended diet and lifestyle again the same as level 1 and level 2. Follow up again at level 3 will be at 7 days or earlier, and referral criteria will be same as mentioned at level 2 plus other modalities which needs to be considered. Now we come to cervical spondylosis which belongs to ICD 11 code FA 80.0 to FA 80.3. If we look at the case definition which we have put in the STGs, the cervical spondylosis is a common progressive degenerative disorder of human spine often caused by natural aging. It is defined as the vertebral osteophytosis secondary to the degenerative disc disease, postural deviations, restricted movement in the affected joints, muscle tissues and neck pain characterizes CS. It typically manifests after an individual reaches their 5th decade. 90% experience this degeneration by the age of 50 years, more in men than in women. Incidence is more in 40 to 60 years of age. Lifetime prevalence is 48.5%, age group I have already told. Now diagnostic criteria which we have penned down in these STGs are, it is typically diagnosed based on the clinical assessment alone. So basically while it mainly causes neck pain, it can radiate to various areas which worsens with neck movement. Neurological changes may be considered, should be checked in the limbs, but they usually appear when the spondylosis is complicated by myelopathy. Other causes like disc protrusion, brachial plexus malignancies, they may be considered when assessing these symptoms. Postural deviations, restricted movement in the affected joints characterize CS. Changes in CS are primarily a result of natural degeneration which we all know. Risk factors again occupational trauma, family history, congenital bone irregularities. Development again follows a degenerative process which leads to biochemical alteration. It results from reduced disc height, narrowing the spinal canal due to herniated disc. These generative changes collectively lead to a loss of cervical lordosis, reducing mobility. Clinical examination, when we do, These are the advanced degenerative changes with audible crepitation during movement, like poorly localized tenderness, limited range of motion. We will be having minor neurological changes unless it is complicated by myelopathy. Symptoms, if we look at cervical pain aggravated by movement, referred pain is there, retroorbital pain, cervical stiffness, dizziness, vertigo, poor balance, vague numbness. Myelopathy, radiculopathy are the complications. Supportive investigations which we have penned out as an essential part of CS is plain or digital X-ray, where we find the narrowing of the disc height, osteophytes, osteophytic changes, osteoarthritic changes. For patients with non-traumatic neck pain and no red flags, initial imaging typically starts with cervical spine radiographs. Again, the ESR to exclude other pathologies or complications, MRIs to rule out radiculopathy and myelopathy. Principles of management, again for the red flag signs of CS, malignancy, infection or inflammation, fever, night sweats, unexpected weight loss, history of inflammatory arthritis, malignancy, infection, HIV infection, drug dependency or immunosuppression, excruciating pain, intractable night pain, cervical lymphadenopathy and executive tenderness. These are the red flag signs which have come. Myelopathy, again we have gait disturbance, clumsy hands, objective neurological deficits, sudden onset in a young patient, history of severe osteoporosis, neck surgery, drop attacks. These are the red flag signs which we have to look into account for CS. Prevention management now involves for CS is excess of mental, emotional and physical stress, which causes headache. We know we have to advise the patient to keep the spine straight while sitting. Basic things which we need to advocate to the patient of CS: avoid forward bending, jogging, running vigorously, a balanced diet to be taken, lifting heavy weights are to be avoided, trauma to the neck to be avoided. I know this may be seeming very, very common to it, but when we apply it in our daily practice, we don't take into consideration. That is why we have to jot it down in our STGs, and we had to put in our presentations too. So you have to bear with me for this revision. So lifestyle modifications, maintaining proper spinal alignment during sitting, standing activities which can prevent the progression. Weight control, yoga, exercises, patient education, which reduces the psychological factors, reduces the impact of psychological factors like reassurance, counseling and education, thermomodalities as we have advocated. At level 1 for CS, at solo physician, we have advised that for clinical diagnosis, again clinical evaluation based on the medical history and the physical examination. However, additional at level 1 will be CBC and X-ray. Studies which have been done in homeopathy for CS. CCRH has conducted trials with the predefined homeopathic medicines showing promising results in CS pain, especially with LM potency over CS potency. And one of the researchers also supports LM potency for pain relief. Bowel nosodes may be beneficial, and Calcarea florica has outperformed individual homeopathic remedies in one survey. We have got a very good result with Calcarea flor also. Yeah. We can share the links with you. Given again the dose, the dosage, potency, everything will depend from case to case and severity of the disease. Now the medicines which we have listed for the level 1 of cervical spondylosis are Actias racmosa, Alumina, Brynia, Causticum, Chelidonium, Calcarea flor, Calcarea fos, Colchicum, Gelsemium, Guacum, Calmia, Lacnanthus, Natrum, Nux vomica, Phytolacca, Radium bromatum, Rustox, Sanguinaria and Silesia sulfur. Adjuvants remains the same. Now these are the recommended diet and lifestyle. We have to tell that after a long period in activity, they don't have to start with the jerky exercises, but we have to start with the routine of gentle exercises like yoga, stretching exercises, strengthening the muscles and improving the postures. We have to stretch, advise the patient of CS to stretch before they start off with any strenuous physical activity. You have to be, these are the basic things. Sit on a chair with, I think you can all see the postural which we have given. This, the rights are the postures which we have to maintain and which we have to advise for the cervical spondylosis patients. We have to minimize the spinal curvature, so we should advise the patient to sleep on the side and always choose a firm and flat surface for sleeping, ensuring a proper nutritious diet and adequately rich in calcium, vitamin D, posture which we have just done. exercises neck rotation, side flexion, flexion extension of the neck, the rotation, but they have to be done very, very gently. We can't advise the patient to do just with a jerk, but these all exercises of neck have to be done with gently, very gently. And we have to hold for 5 to 10 seconds, as I have told you. Deep neck flexion while lying on the floor, the deep neck flexion can be done. Chin retraction, the scapular setting, the scalene stretch, the pectoral stretch, head lifts which we can do by lying down, the chin tucks and the shoulder lifts. So, these are the exercises which need to be advised to the cervical spondylosis patient. Yoga practices again remains the same, only the Shalabhasana is specific for cervical spondylosis apart from the other yoga asanas which have been advocated. So, other yoga asanas are the same for CS, but Shalabhasana, it's like a swimming, when you do a swimming and your body is a little elevated. So, the Shalabhasana is very good asana for cervical spondylosis. Again, for cervical spondylosis, we advise to refrain from lifting weights, improper posture, take regular breaks while driving, use minimum pillows under your neck, soft chairs, avoid leaning while standing or sitting, maintain your weight distribution, stay clear of excessive stress and anxiety, avoid spicy food, fried foods, or those sweet food. And the follow up again here will be done at 7 days or earlier as per the need of the case. Review includes taking a track of individual symptoms and how the condition is affecting the daily life and well-being. Monitor their long term progression. We have to actually see at every level, that's why we are calling at 7 days. Exercise yoga to be mandatory, advocated at every follow up to ask them about the changes they felt. Engage in discussion, assess the treatment and provide your guidance and support. Referral criteria again in CS falls when the treatment does not yield a positive response or when there is evidence of condition worsening or significantly if it is affecting your quality of life. Level 2 again, at level 2 clinical diagnosis will remain same as level 1 or if it is referred from the level 1 or a fresh case. Investigations MRI, CRP, X-ray, hemogram. Again management remains the same, we may continue with the...
X-ray, which view you are most likely to search for the cervical spine? What is the view of it? X-ray का कौन सा view लेना है?
AP दोनों लो, AP lateral दोनों लो ना सर, AP lateral दोनों होगा.
AP से कैसे अंदाज आता है? मेरे को view करके दिखाइए.
मेरे पास सर अभी यहाँ पे है थोड़ी, आप मेरे को दिखाएं, मैं आपको बता दूंगी. Management again, as I told you, it's the same as level 1 and if the patient is revert from level 1, we may continue reassess. Physiotherapy management, as I told you, we have to, in cases of CS, we apply moist heat in cold weather, use of light massage, not a severe massage, employ cervical traction we can do with a 5 to 10 pound force for 10 to 15 minutes. Ultrasonic treatment if required can be done for painful trigger points in cervical and shoulder muscles. Cervical collar if needed can be advocated or it can be advised. Recommended diet and lifestyle again is same as level 1. Restricted diet and lifestyle same as level 1. Follow up 7 days as per the need, and again referral criteria when the patient is not responding to the initial treatment or it is the acute exacerbation are not being controlled upon, or advanced stages of diseases like central or lateral disc herniation. At level 3 again clinical diagnosis same, MRI is there at level 1, management is same, I am not going through it. The only medicines which we have added in the level 3 are Lacan, Paris, rhododendron and Sticta. Apart from the adjuvants here, recommended lifestyles remains the same. These are just a common therapeutic compendium which I have prepared for OA, RA and CS. This incorporates from all the source book and the literature the symptoms of OA, RA and CS for Brineia. I think I don't need to read it, but stitches and stiffness, joint rest, swollen. You can, if you have, if you want to just want me to browse through it, I'll just read it out. Otherwise, okay. So these are all the drugs which we have done, like Vendorinum, chronic rheumatism. Those are the italics which we have taken. Salicylic acid, lithium carb, chronic rheumatism, Cibicifuga, colchicum, guacum, sanguinea. So these are the list of 26 remedies which covers OA, RA and CS in total. So thank you for your patient listening. Acha.
Madam, there are few drops which are there is in level 1 and also in level 3. So how to differentiate?
Sorry,
so
sir?
there is Formica rufa in level 1 and also in level 3.
Yeah.
So how to differentiate their use in level 1 and level 3?
So that depends if a patient is coming directly to level 3.
So that is
Then
duplication of
that's
some
yeah. So that's why we have to write their Formica rufa. Formica rufa maybe they're at level 1, but if I'm not writing at level 3, and if a patient is directly coming to me for at level 3, then Formica rufa will be missed out. That is why we have found the duplication of the remedies also. Are you getting my point?
Some remedies are there in level 1 of the OA and level 2 of
So
the
basically level 1 we have advocated the constitutional treatment medicines only. At level 3 more of the specifics where the acute exacerbation of the cases come. So but the constitutional.
How a drug can be in level 1 and in level 3.
Sorry?
So then how it got standardized?
Thank you, ma'am.